This meeting is now being recorded.
Good morning, everyone. This is Lenita Hartman. I would like to welcome you to today's monthly technical assistance call. We are pleased to welcome Dr. Bridget Burnett, who is joining us now here in August, since we had our little snowstorm and she could not be present at the statewide meeting. So we're really thrilled to have her today. She is a licensed and supervising psychologist in the Children's Hospital Colorado Child Health Clinic for Project CLIMB and serves as the Director of Behavioral Health Integration Initiatives at the Colorado Children's Healthcare Access Program. Dr. Burnett's work focuses on integrated behavioral health care initiatives with the Colorado pediatric primary care provider community, and to enhance and sustain this work with local, state, and federal systems of care, with an emphasis on population health and preventative care with families with children birth to 5. In addition to her position with Children's Hospital, Dr. Burnett is the immediate past president of the Colorado Association for Infant Mental Health and an appointed stakeholder of the CDHS Child Welfare Prevention Steering Committee and teaching faculty in the Irving Harris Infant Mental Health and Child Development Fellowship Program. So without further delay, I'd like to turn it over to Bridget. All right, Bridget, we seem to not be able to hear you, so hold on just a moment. Do you have yourself muted? Do you want me to unmute? Mm-hmm.
All guests have been unmuted.
Can you hear me now?
Yes, we can, but can we ask everyone to mute their phones on their end so that we can have Bridget present her information without any background noise?
So that's *6*. Okay.
So thank you for having me. I'm so sorry I wasn't able to meet with everybody up in Breckenridge, but this is Colorado and how we roll, right? We get 10 feet of snow in May, and then we be innovative and think outside the box to try to do what we can to make things work around our amazing geography and ever-changing weather patterns. I'm very excited to talk with you today about early intervention tools, reflections, and responses. When Lenita asked me to speak on this topic, I think it was really meant to partner off of Sarah McNamee's address to you guys around reflective practice in the context of working with highly complicated children. And one of the goals that I have for the presentation today is to really think about taking, at first, a big step back and thinking from a bigger picture system level, the psychosocial experiences that a very young child may have that impact their health and development, and then kind of dig down into what does this mean for early intervention specifically within the broader systems within Colorado, and then for service coordinators and providers working directly with families that are very complicated and very challenging. Some of you might remember and know that was not mentioned in my bio that I was an early intervention provider myself for many years, as well as the clinical services director at Rocky Mountain Human Services, overseeing the clinical services for children birth to 5, or birth to 3 for early intervention, and then 3 and older on the private services team. So I really do kind of connect to that work and thinking about there are really unanticipated challenges that service coordinators and providers interact with on an every single day basis that really you cannot predict, that are really capacity decreasing a lot of the times, and that really keep us all on our toes. And I very much appreciate all the work that you guys do for children and families with disabilities and delays in Colorado. The first thing that we're going to do as part of taking a step back, if our technology allows us, so again, being innovative today. We're going to try to watch a video together in this first section. And if it doesn't work, then we will just roll with that, and I'll kind of talk about the high points of Nadine Burke-Harris's TED Talk. The video is about 12 minutes in length, which I know can be a little bit long, especially doing a webinar presentation. But I really think that Dr. Nadine Burke-Harris does this beautiful job, much better than I possibly ever could, at walking us through why, when we're thinking about a child's experience, do we need to really be thinking about those psychosocial factors and how they also impact all of us sometimes more than we might be aware of as we go throughout our daily life. So if we can, we'll have the, and I think I should mute myself, maybe.
Yes.
Okay.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California. And together, we opened a clinic in Bayview, Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle, and we were able to provide top-quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids would refer to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, Dr. Burke, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. So higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand, better than we ever have before, how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior, and that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed. So for me, this information threw my old training out the window, because when we understand the mechanism of a disease, when we know not only which pathways are disrupted, but how, then as doctors, it is our job to use this science for prevention and treatment. That's what we do. So in San Francisco, we created the Center for Youth Wellness to prevent, screen, and heal the impacts of ACEs and toxic stress. We started simply with routine screening of every one of our kids at their regular physical, because I know that if my patient has an ACE score of 4, she's 2.5 times as likely to develop hepatitis or COPD. She's 4.5 times as likely to become depressed, and she's 12 times as likely to attempt to take her own life as my patient with 0 ACEs. I know that when she's in my exam room. For our patients who do screen positive, we have a multidisciplinary treatment team that works to reduce the dose of adversity and treat symptoms using best practices, including home visits, care coordination, mental health care, nutrition, holistic interventions, and yes, medication when necessary. But we also educate parents about the impact of ACEs and toxic stress the same way you would for covering electrical outlets or lead poisoning. And we tailor the care of our asthmatics and our diabetics in a way that recognizes that they may need more aggressive treatment given the changes to their hormonal and immune systems. So the other thing that happens when you understand this science is that you want to shout it from the rooftop, because this isn't just an issue for kids in Bayview. I figured the minute that everybody else heard about this, it would be routine screening, multidisciplinary treatment teams, and it would be a race to the most effective clinical treatment protocols. Yes, that did not happen. And that was a huge learning for me. What I had thought of as simply best clinical practice, I now understand to be a movement. In the words of Dr. Robert Block, the former president of the American Academy of Pediatrics, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And for a lot of people, that's a terrifying prospect. The scope and scale of the problem seems so large that it feels overwhelming to think about how we might approach it. But for me, that's actually where the hope lies. Because when we have the right framework, when we recognize this to be a public health crisis, then we can begin to use the right toolkit to come up with solutions. From tobacco to lead poisoning to HIV/AIDS, the United States actually has quite a strong track record with addressing public health problems. But replicating those successes with ACEs and toxic stress is going to take determination and commitment. And when I look at what our nation's response has been so far, I wonder, why haven't we taken this more seriously? You know, at first, I thought that we marginalized the issue because it doesn't apply to us, right? That's an issue for those kids in those neighborhoods, which is weird because the data doesn't bear that out. The original ACEs study was done in a population that was 70% Caucasian, 70% college educated. But then, the more I talk to folks, I'm beginning to think that maybe I had it completely backwards. If I were to ask how many people in this room grew up with a family member who suffered from mental illness, I bet a few hands would go up. And then if I were to ask how many folks had a parent who maybe drank too much, or who really believed that if you spare the rod, you spoil the child, I bet a few more hands would go up. Even in this room, this is an issue that touches many of us. And I'm beginning to believe that we marginalize the issue because it does apply to us. Maybe it's easier to see in other zip codes because we don't want to look at it. We'd rather be sick. Fortunately, scientific advances and, frankly, economic realities make that option less viable every day. The science is clear. Early adversity dramatically affects health across the lifetime. Today, we are beginning to understand how to interrupt the progression from early adversity to disease and early death. And 30 years from now, the child who has a high ACE score and whose behavioral symptoms go unrecognized, whose asthma management is not connected, and who goes on to develop high blood pressure and early heart disease or cancer will be just as anomalous as a 6-month mortality from HIV/AIDS. People will look at that situation and say, what the heck happened there? This is treatable. This is beatable. The single most important thing that we need today is the courage to look this problem in the face and say, this is real and this is all of us. I believe that we are the movement. Thank you.
Since 1931,
All right, thank you so much, Monica, for helping us navigate our technology. I know that that video encompasses a ton of information. Is there an opportunity for us to have comments pop up or for people to share reflections with the video?
Absolutely, Bridget. They can go ahead and write their impressions or comments in the chat.
So I would definitely invite people, if anything stood out to you, was remarkable or new information, or if you just had a reaction to things, to please feel free to share it. I know I've seen this video many, many times, and I always hear something a little new that I think I'm going to take away with me and back into my practice. In general, some reflections that we would think about are the health impact on these early adverse experiences in childhood and how they really can shape a person's health over time in a way that we're just now really being able to see how much of an impact can occur, including a 20-year life expectancy decrease, which is really enormous, especially if you're thinking about a child and what that means for their caregiver if they're in an environment that's psychosocially extremely stressful, how the environment really shapes all aspects of a person's health and health outcome potential. I think that that's really remarkable, and I think for early intervention providers, we're in the child's environment in a way that most other providers are just not exposed to that. So we really get to see and experience that environment ourselves, which oftentimes I think can be very overwhelming while also providing us with significant information around the context of the child's development and what they're experiencing. A huge important aspect of understanding toxic stress and how to prevent it is understanding the importance of buffering relationships for the child. And again, I think for early intervention providers' perspective, we all have the opportunity to provide that space for the child and oftentimes their family members that we're working with, because early intervention is so different than other models of direct service, where we are really inviting the caregivers to actively participate in all of our services to provide buffering relationships that would hopefully mitigate, in some cases even be able to prevent poor outcomes for health and mental health along the trajectory. And something that always stands out to me in listening to Dr. Nadine Burkeras talk is thinking about, it does seem like a biased sample when you start to hear kind of the examples of the trauma and the outcomes, but that original study, which has now been replicated, was done with a sample that was 70% Caucasian and educated and really is more reflective of a wider population and might encompass a lot of us than we would typically expect to hear in thinking about this data. Would we see comments show up if people were able to share those?
Yes, Bridget, they should be on the left-hand screen there for you. And Yasmin did say that this was very insightful for her.
Okay.
Yeah. So some folks were having problems with video and sound, and they do have this link. So if you weren't able to watch it, you can.
Okay. I'm sorry, I had my screen maximized, so I missed that whole column. Now I'm there with everybody. Okay. Oh, and that, Colleen, I see that you're sending trainers to attend that ACES Master Training later this month, which I think is wonderful and a beautiful opportunity to really think about how all of these things really overlap to affect all of the work that we're trying to do. And I think one of the biggest takeaways that we have from a physical health, behavioral health, and development perspective is understanding the family's experience and environment helps us formulate goals that are realistic and attainable. And again, I think from an early intervention perspective, really wanting to maximize every bit of service and dollars that you're putting towards a child and try to impact them as early as possible. You guys are in one of the best positions from assistance perspective at really being in there with the family as early as possible and being able to do some of this really amazing work. But having to hold all of these conceptual points around stressors is, I think, just a lot to think about. So really being acknowledging of that. Next, we're going to look a little bit at, well, this slide really quickly talks about the differences in stress, and I just think it's important to always acknowledge that stress in and of itself is not always negative or adverse. So a positive stress response is really important because, as she talks about in the video, if you encounter a dangerous situation, you need your cortisol system to kick into gear so it gets you out of there. Tolerable stress is another important and healthy response to a situation. It means that we have a reaction to something potentially adverse, but we're able to recover from that, and we're able to recover pretty quickly. So an example that we use in pediatrics is we give shots every single day to little babies, and it doesn't go well, and there's a ton of crying. But most children are very readily, easily soothed by their caregivers holding them, talking to them, offering a pacifier, breastfeeding, and the child immediately calms down. So while they do have a stress experience, it's tolerable because it's very time limited, and they have support to work through that process. And toxic stress is a little different because it's really looking at that prolonged, extended experience of adversity and stress without adequate caregiver support to mitigate, reduce, or protect against the stress. So one of the most common examples to think about with that and thinking about the development of toxic stress in an early childhood population would be something like family violence, where there's a caregiver or family member in the home who might be exposing young children to chronic anger or outbursts or violence against inanimate objects, other children, or a partner, and that really then that stress activation system is going to be chronically elevated, and then that's what really reshapes the health and stress outcomes. We already touched on all of these points, except for I really want to highlight this bullet right here. Average children under the age of 6 had an ACE score of 1.94, and then it just gets higher. That's really important, again, when we're thinking about our early childhood population, because it tells us that by the time a children is 6 years old, they've already had at least 2 exposures in most average circumstances to what would be considered adverse experiences, and they just increase as the children get older and older. And what we tend to see then is school-age children winding up with several diagnoses such as oppositional defiant disorder, ADHD, maybe even some other behavioral health disorders, or getting in trouble and suffering a lot academically. And what we know is that if we're able to really identify psychosocial stressors in a family system as early as possible, we can try to mitigate and prevent the onset and insurgence of new stressors by helping and supporting the whole family, as well as really providing a buffering environment and experience for that very young child. So really important for the work that we're doing. This is data from Sarah Wadamara's study that she did for the Office of Early Childhood back in 2016 that I think is really, really important and exemplary, and probably a very accurate reflection of a lot of the children that we have enrolled in early intervention throughout the state of Colorado. So what Sarah Guatemala did is look at adult ACE scores in Colorado in general from a sample population. And within that, she found data that tracked pretty much along that national data that Dr. Nadine Burke-Harris referenced, which was 20% of adults in Colorado had 2 or 3 ACEs, and 13% had 4 or more ACEs. Again, that's pretty representative and maps onto what we expect from the national survey data. However, she also took a deeper dive, and she looked at children in Colorado in early Head Start. So I think thinking about the early Head Start population and how that might apply to the populations that you would have enrolled in your early intervention programs, 30% essentially had a parental score of 2 or 3 ACEs, so much higher than the national data sample. And 32.4% had a parental score of 4 or more ACEs. That is significantly different and higher. And then when she looked at the children of the parents that had those 4 or more ACE ACE scores, almost 22% had a diagnosis of ADD or ADHD, 17% had a diagnosis of an anxiety disorder, and almost 13% had externalizing behaviors as something that people were working with them on. And I think that's just really huge and important data for us to think about, because one of our goals, and especially thinking about early interventions model, would be to try to mitigate the onset of behaviors that we see in childhood related to a child's environment and development turn into something that would be a diagnosable condition in the future. So I think that's just really remarkable, important data in thinking about that population. Do people have any questions about all of that information? I'll pause for a minute. This is also an unusual style of presenting for me because I really like to be very interactive and collaborative, and so I think we'll see how that goes during the webinar, but I'm always happy for people, if you want to chime in and have questions or have a discussion about things, to try to facilitate that however we can, because this is really big information that I think it can be overwhelming to try to get through in a limited amount of time. So I wanted to also then look at our Colorado's Early Childhood Framework, which I'm sure everybody is familiar with out of the Office of Early Childhood, because I think if we look at the framework around how the system interacts for the child, especially in that prenatal up to preschool age child, we're really thinking about the child and family in context of all these larger environments. And I think that's also extremely representative of everything Nadine Burke-Harris talked about. However, one of the observations I would share is that while all of our systems, I think, are working towards this model of understanding how do we look at outcomes that really focus on access, quality, and equity and encompass all of those systemic modalities, that's extremely challenging when we're thinking about limited resources towards funding, opportunities for engagement with families geographically that can be quite complicated and form what models and services are actually available throughout our state, and that really where we're moving is very innovative, but comes with a lot of systemic barriers and challenges that we're all, I think, trying to push ourselves through, but again, can kind of impact capacity to keep up with the goals and ideals of where we want to be in the context of the realities of the systems that we're all working with. A newer model, also out of the Office of Early Childhood, is the Early Childhood Maltreatment Prevention Framework. And I think this is really important, too, because when we look at the foundational principles, they really are meant to reflect upon that bigger early childhood framework, but really we're looking at honoring the family and participant voice. We're thinking about how policies can integrate better to be really meeting the needs of all the systems of care that we're working with. And the strategies for change, I think, really build upon a lot of the goals of early interventions. So again, these are really great frameworks for us to work off of and to keep us energized and pushing towards how can we be working towards optimal development in child health in Colorado. But knowing that getting to some of these goals is still very much a challenge, especially as we think about our funding strategies and some of our data system cross-sectoral barriers. So if you think about kind of the goals of where we want to move and thinking about psychosocial stressors in the context of child development and health, early intervention's mission and goals overlap so nicely with the other systems of care. It really does provide the perfect opportunity for supporting families, especially diverse families. but is imperfect design at this moment in time for a seamless, effective, efficient support and reimbursement system. And I think we've all kind of navigated some of those pieces together recently, and knowing that we're going through a rapid amount of change across many different parts of our health and mental health system at one time, which can dramatically affect everything that we're trying to do on a day-to-day basis. And the system was not designed specifically to address family, provider, or child trauma. And yet, when we sit with the reality of the day-to-day work that our service coordinators and providers are doing, we actually do. We're addressing, managing, holding, and experiencing very traumatic experiences on a very regular basis. So some of the effects of family stress and trauma on very young children are hard to think about tackling, because things like substance abuse, family violence, and family behavioral health can be intergenerational, and in some of the homes that we're going to be interacting in with our families, the multi-generational approach is right there in the system with us. It might be that the grandmother is the participant during the therapy session, for example. So when the service coordinator is going out to review a plan, there's many different components of the family involved in all of this. But we also need to recognize that some of the most stressful and impactful situations have this intergenerational, multi-generational approach, which means it can be very hard to see systems change at that micro-family child system level. And when we think about the impact of caregiver substance use and child mental health, we know that mental health problems experienced by children of parents with substance abuse can include things like anxiety disorders, attention deficit hyperactivity, depression, oppositional defiant disorder, conduct disorder, truancy, and trauma and stress-related disorders. And again, I think that maps on very closely to what Sarah Wadamara's data demonstrated, in that children who have parents with those higher elevated ACE scores of 4 or more might, even in early childhood, wind up with very serious behavioral health diagnoses. And so is there an opportunity for us to be thinking about how do we understand and manage and work with issues such as caregiver substance abuse within our model and system of care? And again, with family violence, the experiences and symptomology that you're going to see in extremely very young children. We can see some of these symptoms in infants and toddlers. Anxiety, sleeplessness, nightmares, increased aggression are sometimes things that we don't know are going on in a family system when we get a referral for something like an early intervention evaluation. And we oftentimes are not going to know what else is impacting the child and that there has been an incident of family violence unless we get the referral from the Department of Human Services and Child Welfare. But sometimes we might be seeing a child with a presentation demonstrating the symptomology and not always know what's in the room with us. So also holding those pieces and trying to think about what's the whole family experiencing and what do we need to be attending to when we're meeting families for the first time, and working with them and trying to meet them where they are can be extremely important. Long-term experiences with domestic violence exposure can lead to chronic physical health problems, behavioral problems in adolescence, and emotional difficulties into adulthood. So we do want to be cognizant of trying to know what the family and child might be experiencing, but we don't always have that information in a direct or concrete way. So what are some mechanisms we can use to try to know what families are experiencing that might be impacting whole family functioning and health? So one example is a psychosocial screener. So one of the screenshots that you see on the left is the psychosocial screener that we developed at Children's Hospital. We are now universally asking all families about everything from resource availability and access to resources to substance abuse and safety and mental health and behavioral health needs within the family system. And our goal with that is really to try to, as early as possible, identify what some of those psychosocial issues are and provide a response to that family so that ideally we're preventing that insurgence of more and more ACEs accumulating for a very young child, and ideally preventing the onset of any long-term health or mental health consequences and behavioral insults so that prevents them from meeting their optimal development. The challenges with that are having a response system that can effectively manage all of those different aspects of what comes up in the context of a family. The opportunity and what we've learned so far in using this universal screener is we are finding out so much about our families that we had no idea was going on for them, and we're able to really think about goals that might be more realistic and attainable. So from a physical health perspective, I can give a quick example of a child who has never been managing their asthma. They've had asthma since 2. They've been in and out of the ED extremely frequently. They're now 6 years old, not adhering to any treatment plans, and developing other symptomatology based on that lack of adherence to their asthma plan. Well, we initiated the screener. They came in on a day when we were administering it, filled it out, and we learned that they did not know how to navigate the transportation system. They're also an immigrant family who didn't understand what a pharmacy was and how to access and utilize a pharmacy. And so while we've been making prescriptions and treatment plans for years with this family, they were not acknowledging in all the visits that this sounded great. Yes, they understood, they could do it, but the reality was there were barriers that we didn't even realize were there that were impacting foundational aspects of them actually following through with our treatment plan. And so having that information helped us completely restructure how we were going to manage that child's health and what the family needed from us from a resource perspective. Another universal screener that I just wanted to point out that Colorado as a state is really embracing is pregnancy-related depression screening. So on the right, you see the Edinburgh Postnatal Depression Scale. It's one method of assessment for pregnancy-related depression screening because we've really noticed that our data tells us that children who have caregivers who are experiencing postnatal depression or anxiety go on to have developmental delays, and it's a perfect opportunity for us to make sure that we're understanding the baby's development in the context of their caregiver. And I think what we're going to see as we keep moving through our ever-changing healthcare landscape is that things such as universal screenings are going to become more and more common, and also systems are going to be expected to do some sort of psychosocial screening and response as a more universal normative protocol. And while, again, conceptually I think that's amazing because it really does help us shape and understand our families' needs, it is very challenging with our limited funding and resources to be able to implement clear response systems. And I would also say one of the things that we've learned in doing a lot of screening and looking at the data and response systems is we should never be doing screening just to say we did the screening. If we don't have a response and referral system in place to back up any additional screening that we're doing, we need to really think about if it's the right thing for our population. Some of our most vulnerable families may disclose things on a universal screener, but if we're not there to actually respond and support that, it actually can end up feeling harmful and not supportive to the families. So we need to think that. And Monica, I'm seeing your question. Do you have to be trained specifically to administer these screenings? We do recommend that people become trained or at least have some exposure to the tools because there's also some cultural components to them. But for the Edinburgh Postnatal Depression Scale, you have to be, I think, a qualified healthcare provider, which I believe the definition of that for early intervention would apply. Also, in the Children's Hospital Universal Screener is not being disseminated right now. We're still in our validation process. But there are some other validated screening tools where people can get trained by doing either a quick online course or certifying that you've read through the manual and you're able to utilize them. So as in Nadine Burke-Harris's talk, she talked about ACEs, which is the Adverse Childhood Experiences Study. There is a tool that we use in Colorado in some settings called the ACE-Q. So that is not to be confused with the ASQ, which in pediatrics is extremely confusing because we use the ASQs all the time. And the ASQ does have some training that they, I believe, require at least one person in the practice or in the practice setting to be trained to administer. But then once that person is trained, I believe the practice or the practice setting can incorporate it into their daily routines.
Thanks, Bridget. I have one more question.
Sure.
This, on that previous slide, there was something that said SAFER as a screener.
Oh, yeah.
Can you tell us what that stands for? Because that is a family assessment tool that's also used in early intervention, so I just want to make sure that there's a distinction between those two.
I actually was referencing the SAFER that you guys use because I think that that's a beautiful mechanism of trying to really understand where the family is in that moment in time. And while you may not cover all the psychosocial pieces of it, I think it's a really important step towards empirically capturing with a tool how to assess family functioning and kind of what the family is going to most benefit from. So
perfect.
That's a wonderful mechanism that you guys are already doing. And again, I don't think the expectation would be for early intervention to completely change and adopt more physical health methodologies at this time, but I do think it's important to be aware of what's going on in the physical and behavioral health landscape because there's such an overlap, especially when we think about funding structures.
Thank you.
Yeah. So I thought right now we would look at a case example, and again, I would really want people to kind of chime in as we into the next couple of slides around your thoughts and perspectives and looking at this. I feel like this is a pretty representative case example, but I'm also open to feedback about that. So I'll just kind of read through the slide quickly. Joseph is a 2-year, 3-month-old male living in a multi-generational home. His mother is bilingual and prefers Spanish. His grandmother cares for him while his mother is at work and speaks only Spanish. He was exposed to opiates and marijuana in utero, and he has 2 half-siblings that reside with their bio-grandparents. His father is currently incarcerated. Joseph qualified for early intervention due to delays in communication and adaptive skills. He receives developmental intervention once a week with an ECFC. Joseph is making minimal to moderate progress towards his goals. The family has requested a new service coordinator because they think a report to DHS may have been made after the last visit. All Spanish-speaking service coordinators have full caseloads. If this feels really off the mark and no one's ever had a similar experience, you can also chime in and say, no, that would never happen in our CCB. And so really thinking about the supervision challenges that arise with these types of really complicated families who are bringing a lot into the early intervention process. Yasmin, I see you're saying, yes, that's happened. I think that I had a very similar, these are de-identified, and I did make that up, but I was like, wow, I think I'm pulling from about 10 families that I've worked with over the years and thinking about an example. So the service coordinator has come to supervision and has expressed great frustration with everything that's going on, the lack of progress, and the service coordinators feel like maybe the case would be better off being reassigned. Oh, yes, and with CD parents, too. That's a wonderful point. That it's another layer of essential a challenge to manage. So if we were reflecting on Dr. Burke-Harris's talk, what else might you want to know if you're supervising this SC to support them in kind of processing and reflecting on the case and supervision together? And this is meant to be very open-ended. There's no right or wrong answers. So feel free to, if you have some comments or thoughts, to type in. Yeah, so you might want to know, why did they think a report was made? Was a report made? What informal supports are available to the family? So what if the service coordinator had a parent themselves with a substance abuse issue as a child, and that was part of their experience growing up and maybe has shaped some of their perspectives on things? What if they have a grandchild who also has autism or is on the autism spectrum? And what if they recently got divorced due to family violence themselves? Do any of those things feel like, no, that would never happen for a service coordinator experiencing a caseload in their own lives? I know when I was working as a supervisor that I would very oftentimes have my own supervisees going through very complicated things themselves, managing very large caseloads and a lot of stress. And again, there's no right or wrong answers for any of this. But I think one of the things that we try to think about, I know I'm going to ask you to go all the way back in your brains to May when Sarah McNamee did her presentation on reflective practice and trauma, is thinking about not only what's going on with the family, but what else is going on with the service coordinator and how to support them in working through all of the challenges that they're experiencing in their life that are capacity decreasing while they're trying to provide this very, very high level of support to families who are also very psychosocially complicated. And we're not always going to have an overlap in having a supervisee who's experiencing a lot of challenges, but I think it actually happens a lot more than we realize and can really impact how people are able to work through and navigate challenges with families. And I know one challenge that comes up a lot, or did when I was in Denver, was having a very limited pool of Spanish-speaking service coordinators. So if you're in a position where someone wants to make a change and there's been a rift in a relationship because the family is worried a report has been made and the service coordinator is feeling really frustrated themselves and like it might be reassigned, how do you kind of manage that if you also have caseloads where, you know, there's not just somebody automatically there readily available to take on another Spanish-speaking client and make headway? Sometimes that's very appropriate. Sometimes it may not actually be a realistic option to do a reassignment of that caseload. And if the family isn't making progress, I feel like that's kind of a theme coming up in the comments, right? Thinking about why isn't the child making progress and what's going on. Again, going back to some of those key points from Dr. Naeem Burke-Harris's talk, that the service coordinator and the providers can actually provide these really essential buffering relationships both for the child and the family. But if there's some issues around trust or process that are going on, we would expect that maybe not everybody has the right information or that something has happened that has made the trust feel very fragile and there's an opportunity to repair. So one thing that we would think about is if it's appropriate to try to help our supervisees process through all the tremendous things that they're holding with the families, especially seeing them in their home environments, as well as the context of their real day-to-day lives and their own experiences. So now we're going to shift into a little bit of a different part of the presentation, and again, meant to be more of a group exercise when we were going to be meeting all together in beautiful Breckenridge. But I'd like us to watch another short video that we really like to use in our reflective practice when we're working with supervisees and other practices that we work with in the community, pediatric practices, who are experiencing high levels of provider burnout, decreased capacity, and feeling very overwhelmed by the high complex needs of our families today. So Monica, I think what we'll do now is look at the next video, and I'll go ahead and mute my phone again.
I get really mad when my brother hits me a lot. I don't like it when you say you don't want to play with me. When I'm mad, my brain can get a headache and it can start hurting. Your blood keeps pumping because you're like really mad. And you start to get sweaty because you're getting really, really mad. And then when you start getting really mad, you turn red. When your body can't really control yourself, mad just takes over your body. I just get out of control. It's kind of like if you had a jar and would be your brain, and then you put glitter in the jar, and that would be how you were feeling. If you shook up the jar and the glitter went everywhere, that would be how your mind looks. And it's like spinning around, and then you don't have any time to think, and you sometimes punch stuff and people when you don't really mean it. When I get angry, I feel it in my heart. I really don't like when I get angry. The amygdala really reacts, but the prefrontal cortex tries to keep it down. When I feel like I want to, get really angry and yell, I just sometimes, take deep breaths. First, you find a place where you can be alone. Then you find some way to relax and calm down. When I need to calm down, I take deep breaths. I breathe in through my nose. Sometimes I close my eyes or just take deep breaths. It's calming down, it's not moving. It's slowing down and then it stops. And the heart pumps slow and then it goes into your brain. It's all the sparkles are at the bottom of your brain. My brain slows down and then I feel more calm and then I'm ready to speak to that person.
All right, thank you so much, Monica, for putting that video up for us. Do people have any reflections or reactions to that video? One of the reasons we really like using this video with our supervisees and the practices we work with is because in the moment, even for me, just kind of reading through that case example, I can feel my heart rate is probably beating a little faster. There's so much to process and think about, and there's an immediate tendency to start feeling very activated around all these components for safety and trying to think about how can I be helpful right now when all of this is going on. And I love the example of the little girl in the video who talks about the glitter jar and that it's it's all just swirling around and her brain is moving so fast. And if you breathe and calm down, gradually your brain will start to calm down too. And so what we actually do is we'll show the video and then go through an exercise of making glitter jars. And I actually was going to bring them and we were going to make them at the retreat in Breckenridge because I thought that would be a really fun thing to do together. But I think it's something that is an activity you guys could all think about taking back to your individual teams and think about if you would want to use this as a tool to incorporate into your team practices or your supervisory structure. I have people that I meet with on a regular basis where they kind of thought it was a little hokey, but now when we start talking about things, they'll reach over and say, I need my jar. I'm going to shake my jar up because that's how I'm feeling right now. But I know I just need to really sit with this and think about, okay, we can manage this. I can work through this. I need to recenter and regroup and think about how do I proceed and manage? And it's also a beautiful opportunity to think about modeling that for caregivers who might be very overwhelmed and not able to process all the information related to their child's disability or all of the recommendations and goals or even paperwork that we're trying to give them, as well as being able to model that as an activity you can do with very young children, that they can kind of they can respond and get it. And I love that the video is narrated by the children, and then the grown-ups are the ones actually doing the activity. I just think it's a really nice tool for us to use. I'm trying to read through the comments very quickly. Yeah, so it seems like people are familiar with glitter jars and that there's lots of resources on how to make them quickly and easily. Pinterest is everybody's friend unless you're glitter adverse, which a lot of people are very glitter adverse too. It does get everywhere and is very hard to clean afterwards. Monica, can we go back to the slide, or am I? Oh, okay. All right. So I love this quote by Dr. Seuss. If things start happening, don't worry, don't sue. Just go right along and you'll start happening too. Again, I think it's part of that we can get very overwhelmed and frustrated, as can our families, as can the children that we're trying to support in the work that we're doing. And we do need to find ways to try to process the information and stay engaged and feel like we still have capacity to keep working through things in a deliberate and meaningful way. So when we're thinking about working with really complicated families and how to manage supervision and the experience for our providers and service coordinators, being really attuned to opportunities for reflection, how we respond to families and to each other in those circumstances can be essential, and thinking about if there's an opportunity for reframe or repair. So we'll talk about that a little bit. I think that Monica may have sent out the handouts. You guys got these all, I believe, about a year ago. I want to say it was August 2016. Karen Frankel and Betsy Rogers, I think, did a reflective practice training also and provided lots of tools. And so these tools are from that training, and thinking about ways to incorporate these into your time and your practice. And when I was originally thinking we would do this in Breckenridge, we would have ideally assigned each table or group one tool to process that case example with, and think about how you would apply this based on some people being the service coordinator, some people being the supervisor, some people being maybe the family member that the service coordinator was having a difficult time with, and seeing which of these tools, or how these tools felt to use so that people could take them back to your individual sites and think about how you might weave them into your practice. Is anybody currently using any of these tools or strategies? And if so, do you have any thoughts, reflections, or things that you'd like to share with others who may or may not also be using them? So we have the parental difficulties exercise is one of them, where you present about a family together, and there's very structured questions around what you're going to explore that kind of help you dig into, if you're at your wit's end or feeling very frustrated, what else might be going on or in the space with you. The collaborative problem-solving sequence kind of helps people walk through how they initially respond to things so that they have a little more insight into their process and working with challenging situations. The early intervention tracking infant and early childhood mental health. This might be the tool that you're mentioning, Colleen. I see you just popped up. We use a reflective case presentation strategy that was provided by Betsy. I am very familiar with that tool too. I'd be interested in how you feel that works for your group, and if you have any thoughts you'd like to share about it. That can be very useful. It does typically require there to be a lot of in-group trust, that it's a safe space for you to really kind of dig into some of those reflections for sure. And the handout that is questions that encourage problem solving. So some people are not going to be as comfortable with a reflective process, and I think that that's normative and shouldn't be criticized at all. So having questions that are pretty pragmatic and help them work through the problem, it can be a more structured, helpful, pragmatic approach that's just going to be a better fit for some people and their approach to interacting in an individual or a group setting. So, Colleen, I love your comment. It is much more comfortable for our early childhood mental health type staff, but the teams feel it helps them get to better problem solving. Again, I think that's the beautiful thing about having multidisciplinary team members. You may have people who are all in for reflective process and are going to always be willing and able to go there, and people who maybe aren't as engaged in that but still find it to be helpful. So thank you very much for sharing that. And this is a planning management tool for managing secondary traumatic stress. So this is really meant for the individual to kind of look at the activities that they have in their life and what they need to feel recharged when they're feeling overwhelmed or that the secondary stress or trauma is really starting to impact them. I think that as adults, we sometimes don't realize how impacted we are by a situation that's very, very stressful until we start to see physical signs of stress or feel less engaged and less satisfied in our work. But oftentimes it's hard for us to really kind of pinpoint what it is about our day-to-day life that's stressing us out, and we may need some tools and guidance to try to walk us through this. Even as a psychologist, I can tell you that, spends a lot of time thinking about reflective process. I'm very guilty of that. Life moves very fast, and sometimes we need different mechanisms to guide us through what's preventing us from doing what we would like to be optimally doing. And the professional quality of life scale. I know that some organizations have moved to using this more universally, which I think can be wonderful. And again, it's really helping people tap into, if there's parts that they're not as satisfied with right now, what is that like? And if there's opportunities to make things more satisfying and engaging, how can we do that? Which again, for early intervention, the work we do is so important, but our caseloads are very high, and the amount of issues that we're juggling are just really impactful. Trying to retain our workforce can be an ongoing challenge. So this was, again, the group exercise we were going to do. We're not going to do that today, obviously, but I would still encourage people to consider taking the group exercise that we were going to do all together and think about, if you haven't applied any of these tools in your organization yet, if you might want to go back and do a similar exercise together and see what tools are a fit for your team or your organization to help kind of move people through retaining capacity while working with these very, very complicated kiddos. And again, trying to think about how do we navigate things. The right dosage of an intervention is always a tricky thing. We have lots of tools that we can do to try to streamline understanding where our families are coming from. And then there's those basic Maslow's hierarchy of needs components that we sometimes aren't aware of but are essential, like nutrition, exercise and physical activity, sleep, mental health support, but really emphasizing the importance of supportive relationships. And that supportive relationships bucket is meant to be not only for the child and family through the service coordinator, but also on our teams, so that, again, we have a process that feels really supportive and healthy for people as they're engaging in this highly complicated, often extremely stressful work. So I'd like to open it up for a few minutes for questions. And Monica, I know you guys have some other things to cover, so if we have a time limit on this or we need to be wrapping up, please let me know.
Okay. I think we have like 10 more minutes before we needed to talk about some additional things.
Okay, wonderful. So really related to this, or any other specific questions people have, I'm happy to do what I can to be responsive.
If you guys want to go ahead and unmute yourselves if you have questions for Bridget, now that we're not the presentation's over, we don't have to worry about background noise as much. So if you guys have anything that you'd like to discuss with her, feel free.
Can you hear me?
Yes.
Hey, hi Bridget, this is Laura from the EI team.
Hi.
I'm just wondering about further implications of perhaps bringing screening in around toxic stress and trauma a little earlier. Have you experimented with that anywhere other than in medical settings?
Oh, that's a wonderful question. So thinking about applying that to other settings. Right now, actually, there's an initiative in the state to pilot doing psychosocial screening in school-based programs, which would include early childhood programs.
Interesting.
Also, some of the home visiting programs are looking at if they would want to adopt universal psychosocial screening measures. And again, I think it's really it's setting and system specific about if that's the right thing to do, because the real risk is identifying issues in a family and not having a referral or response system that's able to respond and coordinate. So if you're able to incorporate and respond to the information in a meaningful, helpful way, that is would be one mechanism of trying to figure out if that's the right thing to do for you. And if you feel like you could not, that would be really understandable. So I don't know if any of the people participating in the call today are part of any of the Launch Together sites, but Launch Together is a nonprofit-funded version of Project Launch that's in 5 communities across the state of Colorado, and it's looking at 5 areas of deliverables. One would be screening and referral, so very much close to early intervention. Another would be enhanced home visitation. Another is integrated behavioral health and primary care. Another is caregiver parent training and engagement. And now I'm blanking on what the 5th one is. If somebody who's listening can remember off the top of their head, you could definitely chime in. But those communities are looking at things like, in doing their screening and referral process, would there be, for example, an opportunity to take screening that's happening in one part of the system and communicate the results of that screening to another part of the system? So if the child is being screened in their medical home primary care setting and they're 6 months old and they're also being referred to early intervention, should they be sharing some of that information across the system so that the service coordinator has an idea of what the medical setting is already trying to address and has resourced to do at this point, and can kind of incorporate all that knowledge into their service coordinating and planning for the family, or if there's gaps in what the medical home can do that the early intervention service coordinator system could pick up. So I think those are some broad examples, and all those how these are in the early stages of looking at things like that. But I think that's a wonderful question to think about.
Yeah, thank you, Bridget. That does make me think about, something that many of these families that you're being identified as affected also are involved with multiple service systems. Absolutely, and I think that's what I was really thinking about in the slide with all the different approaches and models and frameworks that we have right now, and how I think idealistically and philosophically they are the exact right approach for our families. But when you get down to the nitty-gritty and think about basic sharing of PHI, sometimes caregiver, sometimes child, and data systems, it actually is really complex and burdensome and hard. And if there's opportunities for us all to work together to make that more effective, I think it would underscore the work that we're all trying to do to make it much more impactful. Because how effective is it for me to screen in primary care, and for the early intervention team who's also going to service that family to have no idea what the screening results were, and what we've been working really hard on with the family from a basic needs perspective. Right. That seems like a loss from a care coordination perspective, but right now our system is not really designed to work that way. Mm-hmm. Thank you.
Yes.
Great. Thank you so much, Bridget. We really appreciate you taking the time to provide this information to the group today. And, it was really unfortunate that we weren't able to have, or you weren't able to join us up in Breckenridge, but I'm so glad that you were able to share with us today. So thank you very much for doing that.
Thanks for having me, and thanks for being flexible with videos and glitter jars and trying to use our technology to facilitate a reflective process conversation. So thank you.
Yes.
All right, I will hop off, but you guys have a wonderful rest of your call.
All right, thank you.
Thank you.
Okay, so Christy wants to provide some information about the MOU for CSDB that some of you have asked about. So
many of you, I know MOU from the Colorado School for the Deaf and the Blind was sent out to each community-centered board last week. I know one got one even a little bit earlier than that. So all of you should have seen it. If not, it's probably floating around somewhere. We just wanted to let you know that we have not seen the MOU until it went out to the community center boards, and we're reviewing it right now. And we'll be reaching out to CSDB to have a conversation about these MOUs. Our advice right now is that CCB should not be signing these MOUs. We want to be able to provide guidance regarding some next steps about the intent behind the MOUs and what they're for. These particular MOUs are more contract-like in nature and not very clear. If any of you have read it, you would notice that the term of the MOU is already expired. The date on the MOU is June of 2017, so it wouldn't be helpful to sign this particular version of the MOU anyway. We don't have a lot of information, but would be happy to answer any questions or hear any feedback. I did want to say that, our expectation would never be that individual CCBs would have an MOU with a state agency. If we feel like that's a necessary thing to have, then we would absolutely be engaging in those conversations with CSDB to enter into a state level MOU, and then if anything became necessary at the local level, you guys could do that work. Are there any questions, comments? I would appreciate it if you do have questions or you have received any additional communication between yourselves and the CSDB. If you could just copy me on it, it would be really helpful so that I can know what's been happening. We were not involved in this at all in any way.
All right.
Thanks.
Beth, are you on the line?
I am. Can you hear me?
Yes, we can.
Okay. So I'm starting to get some questions about the rate for targeted case management for early intervention because apparently some communication went out to the CCBs about an increase in rate for the waiver programs. So CHCBS, the CLLI, all of the different waiver programs. The rate is now $16.09 instead of $15.87. I am checking with Medicaid. I have responded to a couple CCBs saying that the rate is still $15.87, but then it occurred to me that there was a rate increase, and so I am checking with Medicaid to see if the rate was due to the across-the-board rate increase or if DIDD had requested an increase in their rate, and that's why their rate is higher. At this point, I would recommend that CCBs charge the higher rate because if it is the higher rate and you charge the lower rate, you'll only get paid the lower rate. If it is still the lower rate and you charge the higher rate, you'll get paid the lower rate. So anyway, I will let everyone know as soon as I hear back from Medicaid as to whether or not this was part of the overall rate increase or if this is something specific to DIDD.
All right. Any questions about that from anybody?
Hi, this is Pat in Community Connections, and I just wanted to verify, did you say 1609 was the higher rate?
That's what I have heard.
Okay, thank you.
Okay, if you have further questions, go ahead and reach out to Beth, and she can connect with you on those. All right, so just some more updates for you. This will probably be your last reminder from the state team, but fiscal year 16-17 indicator reports are due close of business on August 7th. Please complete all of those reports that are located in the folder. Ashley Ness is able to unlock any IFSPs that you may need access to enter that data, or if you have questions. She is out on vacation right now, but will be back on Monday. If you need assistance, today or tomorrow, you can contact Ashley Fernie, and she can help you right away. Otherwise, Ashley Ness will be able to help you when she is back on Monday. So, last reminder. Another update that we just wanted to share with you is that a Padlet has been created for fiscal year 17-18. It used to be that all of the slides for TA materials or additional kind of pieces of information or handouts were all posted directly on the EI website. We're going to be trying this new way out right now to see if this is a better way to have things organized for everybody. There's a link directly to the Padlet on the EI Colorado website under the 4 CCBs tab, Technical Assistance and Monthly Technical Assistance Calls. So you will find the PowerPoint slides there, link to the recordings, schedules, or other reference material. So thanks everybody for your patience and for letting us know when things may not be working on the website, and for providing us with kind of that eye so that we know how things are working for you. So continue to just let me know if you come across anything that is not working or you can't find. All right, that concludes our call for today, unless anyone has any other questions that we can answer for you. Any questions? Okay, someone's beeping. All right, well, thank you, everybody. I hope you enjoyed Bridget's presentation and information, and I sent out all of the resources and the links to the videos yesterday in an email to everybody, and then they will also be posted on our new fiscal year 17-18 Padlet. So thank you, everyone, and have a great rest of your week.